Greetings and welcome to today's webinar on Getting to the First 90, Engaging Men in Self-Testing. My name is Jennifer Pearson, and I am a technical advisor with the AIDSFree project. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations, followed by a discussion period, during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are only visible to you. I'm sorry, can everybody hear me?
Yes, we can, but you're breaking up a bit.
I can hear you clearly.
Wonderful. I'll go ahead. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are only visible to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your questions for our speakers and will save them for the discussion period. It's great that we're able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting tips if you have any technology challenges today. A few tips. If you lose connectivity or cannot hear, close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. Use the Q&A box to ask AIDSFree Tech for assistance. If the troubleshooting steps are not successful, please rest assured this webinar is being recorded and you will receive an email with a link to the recording following today's event. Questions that don't get answered during the Q&A sessions will be compiled after the webinar, shared with our presenters, and responses from presenters will be shared with participants. To get us started, I will now turn it over to our co-moderator, Vincent Wong.
Hi, thanks, Jennifer. Hello, everybody. Good morning, good afternoon, good evening. We've got a good group of people engaged from across the world. My name is Vincent Wong. I'm a senior technical advisor at USAID for HIV testing services, and we've organized today's webinar with AIDSFree, and I'll be co-moderating the discussion session following the presentations with Melissa Scherer, Senior Technical Advisor for AIDSFree. And we've convened this just to do some thinking around reaching the first 90. So for those who are maybe unfamiliar, the 390s have been goals set out by UNAIDS, and the first 90 is the critical one for us is diagnosing 90% of people living with HIV globally. Right now, the global estimate is somewhere between 51 and 54%. And we've done a decent job over the past 15 years reaching that, but getting to 90% will present increasing challenges in reaching people who are yet to be diagnosed. So we've got 3 presentations to try to address the question of how we get there, self-testing and reaching more men. And we've gathered a good group of international thought leaders to provide their considerations on thoughts on that. So we will start off with 2 speakers, Nomea Masuleho and Ananthi Tambin from USAID South Africa, to present their findings on male engagement. So take it away, Nomea and Ananthi.
Good afternoon, my time. Good morning, wherever you are, and good afternoon, wherever you are. It's Nomea Masuleho
and Ananthi Tambin.
Yes, we have put a very short period of time to go through the slides that we have prepared and to share with you. And we hope to actually do that within the 15 minutes that we are allocated. And we hope the moderators and the organizers will actually be able to share the slides with you after our presentation. Our presentation is in relation to a research that was commissioned by USAID, with one of our partners to look at how to can create the demand creation for women. And they started off with a formative research increase men's uptake for HCT, which is part of the key strategy for achieving the first 90. What we actually understand is that almost 3 million people in South Africa, almost 3 million, 6.5 million people living with HIV are on treatment. As you can see, the graphs on the presentation that are adapted from Johnson et al.'s mathematical modeling, they show that higher proportion of males remain undiagnosed, people in the ages of, which is almost 60% of the male population, and there is also lower treatment uptake than females in the same age band. Deeper into the methodology, but I just wanted to share with you that our partner commissioned CADA, which is a local research group, to conduct this formative research so that they could actually come up with activities for demand creation for mental HCT. There were female participants who were secondary sources on issues of men. Most males describe themselves as single or integral relationships. Only 2 out of the 97 participants in the study were married. Focus groups were held, and individual interviews were conducted in different languages. This was done in a variety of geographic areas in South Africa, and it was in 6 districts in 5 provinces in our country. What we have realized is that the findings from this study, and I have got to say that I'm not doing it justice, summarizing it for this presentation. We can share the report with you or with the AIDSFree folks, was that we could actually categorize up the key findings from the study in what were the enablers for men to participate in HCT. We realized that there is more progress in terms of level of awareness and knowledge about HIV and HCT. They actually had relatively high knowledge of these two, HCT and HIV. Now just actually getting into the barriers for HCT. We have also stratified these as 3, the psychosocial factors that were barriers, and also structural or facility-based barriers. The essence of these barriers are captured in the participants' own words, the psychosocial barriers. And additional slides provide a range of quotes from the participants. These are not going to be presented in any order of magnitude. In terms of male norms, some of the men have actually indicated that taking an HIV test, male masculinity actually extends to HIV testing, stating strong men do not get sick and do not seek help, or also testing by proxy. Fear of death. It was very interesting to understand or see that in 2015, men still found that with the knowledge and awareness about ARVs, people still felt like knowing their status would actually be a death sentence. There is a lot of denial of risk or inevitability of infection. Given what we aim to achieve, the most important challenging finding is the belief that it is better not to know one's HIV status. Stigma and fear played a key role in as far as men not accessing HIV counseling and testing services. There was fear about disclosure of their status if they tested positive. There's also, the research has also found that stigma related to HCT and condom use, that men believe that by going for an HIV test and using condoms, It meant that one is already infected and or is practicing risky behavior. As a result, friends could not imagine suggesting HCT to each other. One of the barriers was that there's a mistrust of HIV tests. Some men HIV positive men believe that the needle that is being used at the clinics can actually infect them with HIV virus. Barriers related to HIV health services. The formative research identified a number of significant health or structural service-related barriers. Men are not used to go into clinics, so women go regularly. Participants found that clinics are not very friendly. The signage of the clinics, like a blood room or TB room or BCT room, when entering such rooms, they found that it meant they are, everybody who's at the clinic will know that you're going for an HIV or you are already HIV infected. Additional barriers in relation to health services were related to health workers. Participants raised concerns about health worker attitudes and bad treatment towards clients. The other barrier that men found was that restrictions during counseling, where they found them to be intrusive by those who actually went ahead and tested. Participants also found that the quality of pre-test counseling was very discouraging to proceed with an HIV test. As for example, counselors would tell if you test your life will never be the same again. So again, how we conduct or service providers conduct counseling and testing actually had an impact on what made it difficult for men to access HIV counseling and testing services. Now let us look at the HIVST enablers. The researchers found several factors that enabled men to test. Physical symptoms of firstly physical symptoms. Persistent health programs encourage men to seek health services, including an HIV test. As a result, men who are asymptomatic will not be found in a facility. People living positively can be the best champions for encouraging men to test. Partner-related factors. Participants were encouraged to test by their male partners. A study in Malawi showed effectiveness of HIV partner notification and greater opportunities for HIV treatment. This study also found that partner notification, referral, linkage to care and treatment, I seem to be missing. Okay. There were the partners' recommendations, which actually have been able to show on the screen. But I wanted to actually touch on what are the implications for PEPFAR's HIV counseling and testing. Quickly, let us say that barriers to ACT are barriers to epidemic control. We need to address this at the start of the cascade. Counseling needs to focus on ART. Progress on ARVs and access to HIV treatment needs to be public knowledge, especially among men. Men are not a homogeneous group. There is value in extended and innovative efforts and more cost to reach this priority population. We have to leverage the enablers to HTC uptake. Models that have proven successful with reaching key populations can and should be scaled up to reach men with testing, linkage, and ART initiation services. For example, peer-to-peer models that is mainly linked with key populations. Innovations in the service delivery model for test and start should be scaled up. A randomized clinical trial in Malawi on optional home initiation of HIV care and ART initiation following a self-test showed a significant proportion of those in the home group initiated HIV treatment compared with those who were in the facility group. Demand creation is key to reaching men with HCT linkage. So before we conclude, I would just like to actually give my colleague a chance to briefly talk about how this study has been applied.
Thanks, Nomea. I just want to draw on or sort of follow up on the point that Nomea made on demand creation, and it's important. So as Nomea mentioned, this formative research was really done to better understand why men are not testing and what the barriers are to testing, as well as some of the enablers to testing, so that we could think of useful demand creation activities to support a range of activities that we're doing to increase HCT in South Africa. I mean, the study does touch on both service delivery as well as demand, and we're using this particular formative study or formative research to address the demand side. The study also goes through a range of issues, and the partners that we are working with, the Center for Communication Impact, formerly known as HIVST, the Johns Hopkins Health and Education Program for South Africa, chose to focus on one particular area of fear, and that's the fear of positivity. And they're doing it through an award called Strategic Evidence-Based Communications Interventions. This award really looks at using social behavior change communication to address key issues that PEPFAR South Africa is going to focus on. And it's using the suite of classic SBCC activities such as television, radio, billboards, social media, and other activities, and to address key interventions that PEPFAR is going to focus on in South Africa. And this includes SGBV, medical male circumcision, HCT, consistent condom use, as well as dual protection. In this particular area, in this particular study, is focusing on HCT, but the award has been working to address those other areas that I mentioned. The award also draws on two big campaigns that address men as well as women in South Africa that are very well established, and this is Brothers for Life. And it's really created a kind of a campaign image that we're hanging our hat on. And this is also in line with not just PEPFAR 3.0, but the National Strategic Plan in South Africa. Okay. So essentially, the we're using from this is going to develop a television PSA, a radio PSA, then supplementary materials such as posters that we feature in a tavern or a bar, those clinics, billboards, a series of short documentaries, and the use of mobile health elements such as social media, as well as mobile television. The next slide sort of shows an example of how we've used these types of media elements to link directly to service delivery. So this is an example of a billboard that we developed for medical male circumcision. What's circled here, the next one, you can see faintly, is an SMS geolocator that if you use that SMS number when you see that billboard, it will use your location to send you the information to the nearest clinic that provides medical male circumcision. So we're using BCC to address some of these fears and norms that came up very clearly in the formative research, but we're also then using it to directly link those individuals to services. And we've seen this work with male circumcision. We're hoping that it's going to work with the HPT campaign that we're developing. The campaign is currently in progress. We have some wonderful draft pieces we wish we could share with you, but we're still in a draft phase. But I think the point of all this is to say that the evidence that we have found in the formative research shows that there are some very basic barriers to the uptake of HCT in South Africa, and that we really believe that in addition to strengthening our service delivery and thinking creatively on how to reach communities with HCT, we also have to invest in demand creation. And demand creation must be part and parcel of this activity for us to reach the 90-90-90 in South Africa. So I'll stop there and take a moment to thank Cadre, which is the research team, as well as Center for Communication Impact, which is the implementing partner, and my colleague Nomea, who is our HCT expert in South Africa, as well as the folks in OHA who have been very supportive of us sharing this research as well as the activity, the demand creation activity.
Okay, thank you. We will hand over to our moderators. Thank you so much.
Thank you, Nomea and Anathi. We really appreciated your experience, both based on your research in South Africa and also, probably most importantly, how you were able to apply it in programs to start to look at how to make a difference. I think how you're talking about focusing on men as a special population is a key thing for us all to think about more deeply and using the knowledge that we get to create the demand for the services. Please, everyone on the webinar, please continue to add your questions for Nomea and Anathi into the question and answer box for our discussion session at the end of all three presentations. The next presentation is from Cheryl Johnson of the World Health Organization, and she's going to give us an overview of HIV self-testing. So I'd like to introduce Cheryl Johnson now. Go ahead, Cheryl. Thank you.
Great. Can you hear me? Okay, I'm just going to go ahead, maybe turn this up. And thanks so much for the opportunity to present to you. As Vincent kind of touched on in the beginning, we've really come a long way in the work that we've done, and just looking at some of the data, back in 2005, only 12% of people who wanted to have an HIV test were able to, and 10% of people living with HIV in Africa knew their HIV status. So we know in 2014 that we tested over 150 million people in low and middle income countries that reported, and we also know that we have about 51% of the people living with HIV in Africa who know their status now, which is a huge achievement. But we also know that when it comes to the 90-90-90, the first 90 is the most problematic, and we have this gap to reach this 46% of people living with HIV who don't know their status. And the current testing approaches are just not enough to get to 90. They're not being implemented to the scale that they need to be and supported to diagnose this remaining 46%. And so I'm going to be talking to you today about HIV self-testing as an additional tool to create demand for HIV testing services and increase access, uptake, and efficiency. And this is an area where we know our public health response is lagging behind the public demand for self-testing. So there's a need to catch up. And so I'll give an overview of kind of what we know today and what we're doing at WHO. So just in general, when we talk about HIV self-testing, we're talking about a test that's a reactive result that needs confirmation by a health provider. So an HIV self-test cannot provide a diagnosis. We also know that it's formally and informally available in a lot of settings. So you may see it in your country or in your context, but that doesn't necessarily mean that it's a regulated test for self-testing. So you can see just some of the pictures we've collected around the world of where you can find self-tests. So those at the top are those that are available formally, and then those at the bottom are those that are available informally. So in terms of where countries are at, in terms of the policy, it's a fast-moving field. So we've got kind of on that bar piece of policies and products that are approved for self-testing. So that's ideally where we want to be. So you can see those countries. And then policies that explicitly allow self-testing, but they may not have a rapid diagnostic test that's licensed and registered or regulated for use for self-testing. Then policies under development, those are countries that are actively engaged in working on this. And then we also have reports from countries where self-tests are available informally. So in December of last year, WHO and UNAIDS did a landscape analysis of the market and identified 15 different rapid diagnostic test manufacturers that are engaged in the self-testing market. And 3 are approved by a member of the Global Harmonization Task Force, and none are currently WHO pre-qualified. So it's 10 rapid tests that use finger stick whole blood and 5 that use oral fluid. In terms of formal sales, we don't have a lot of reports, but what we do know is from the UK and from the US. In cost, in high-income countries is around $28 to $40. For research in low and middle income countries, we're about $3.50 to up to $16. And then for sale informally, we're around $4 to $10. So these are the tests that we identified that have the approval by the Global Harmonization Task Force. But as you can see, the price can be very prohibitive for resource-limited settings. So this is one of the key areas that hopefully the WHO guidelines and other work will begin to address. In our estimates, using kind of the global AIDS reporting the GARPR, I'm sorry, I'm so used to speaking in acronyms, and I'm sure a lot of people on the call can relate to that. But the GARPR estimates, as well as other modeling, we were able to estimate that about 4.8 million at least of RDTs would be demanded if self-testing was introduced by 2018. So the estimates that we were able to create are very broad. But that's also because we don't really have great information, our country or validated population level information of demand and market size estimates. But it could be potentially as high as 88 million depending on how it's implemented and what the frequency of testing, the uptake and potential reach of those populations that are currently not accessing testing services. So currently in our WHO guidance that came out in July of last year in 2015, outlines the different models, priorities and policy issues, as well as evidence gaps. And it also encourages countries to conduct pilots and demonstration projects. And with lots of partners, we maintain a website, HIVST.org, that has lots of information and maps out the evidence and policy on self-testing. So that's a really great place to go if you're trying to get familiar with what's happening and where is self-testing happening. And there's also an easy collab group where you can access resources and the latest articles and presentations on self-testing. So I encourage you to do that if you're interested in this area. So I'm just going to give you a quick summary of what we know. So in terms of acceptability and willingness, we've indexed 51 studies which report that self-testing is generally very highly acceptable and people are very willing to self-test. In terms of uptake, the data that we have from Malawi really shows us that uptake can be really high, especially among young people. So you can see the 16 to 29 age group, especially young women and young men, that are first-time testers. So 44% of those testing were first-time testers. And it's really incredible to see this about the challenges that men might be experiencing accessing existing testing services. So the potential for self-testing is really huge here. In terms of increased frequency, we see, especially among men who have sex with men, that self-testing can increase their frequency of testing. And this is really important because men who have sex with men, as well as other key populations, benefit from frequent retesting. So current WHO recommendations say all key populations should be tested at least once a year, but as up to every 3 months or 6 months, depending on their risk. So this is something that could have a high public health impact where there's low testing coverage and where, in terms of accuracy, we've done a systematic review. And we've identified that it can be good, but not always. So HIV rapid diagnostic tests can be used with about 99.1% sensitivity and 100% specificity. But it really depends on the rapid diagnostic test that's being used, the instructions for use, the populations, and the setting. So what we identified in our review is people that are on ARVs or know their HIV status that are self-testing to see if they've been cured or to see if their treatment is effective. We're not exactly sure why some people that are living with HIV are self-testing. We have some questions about that. But it does occur, and that can really reduce the sensitivity of an HIV self-test because it's really for people who are HIV negative who don't know their status. So this is something that we highlight in this review, and I can give some more details if that's useful. Oh, I'm cutting out. Okay. I hope this is better. In terms of linkage to care, we have limited information, but it's promising. So we've seen that linkage to care can be good, especially with the offer of home-based assessment or ART initiation. So this was something that was shown in a trial done in Malawi, and you can kind of see the results there on the slide that when self-testing was offered with this proactive linkage approach, that linkage was quite good. and increased threefold compared to the arm that did not have that home assessment and ART initiation. And then we also know through some survey data that people report that they would be likely to link. Although this is not the best type of data, it does give us an inclination that people with a reactive result may be likely to link to care. So this is something we'll be looking at further in our WHO guidelines coming up later this year. And in terms of adverse events, what our data is telling us is that self-testing can actually be empowering. There's no adverse events as a result of self-testing for multiple diseases and conditions, including HIV, that are published in the literature. However, we do know of some anecdotal reports, and this is an area where there has to be really good monitoring and reporting systems to identify and address when and if social harm occurs. And information and messages for communities is particularly important here, especially for vulnerable groups, to make sure that communities are sharing and understanding what self-testing is and encouraging its correct use. We know that's critical with HIV testing services today, that the communities are essential to service delivery and ensuring that there are no preventing adverse events, preventing intimate partner violence. So that's a really important part of self-testing as well as HIV testing services. There are a number of tools that are being used, so hotlines and mobile phones and SMS, community-based monitoring systems, community computer programs, and post-market surveillance systems. So all of these are being kind of utilized to look at adverse events, look at linkage to care, and lots of the questions that we have when we take testing out of the facility and we don't necessarily have that patient record available right in front of us. So it really brings us to this impasse of what do we need to do to get self-testing going. So there are some implementation pilots that are underway, and some of the big gaps we've outlined are, does self-testing, is it going to have a public health impact? Is uptake going to occur among those at risk or who may not otherwise test? Is self-testing, how can we optimize it? Will it improve case finding? Will it lead to early diagnosis, linkage to care, support, social harm? Is that going to be an issue? Performance and accuracy, the quality of services and the test, the monitoring questions, the cost effectiveness, and the demand and supply. So we have a lot of questions, and so WHO will be having a guideline meeting in July, and we'll be issuing recommendations and guidance in the coming year, so December 2016 is our goal. Also, the Global Fund has the expert review panel process, which they will be launching an expression of interest at the end of this month for manufacturers to respond and to prioritize HIV rapid diagnostic tests for self-testing. And also the PQ team here at WHO, they've put out a sample dossier for public comment, and so there will be a pre-qualification process for HIV rapid tests for self-testing. So there's lots of things going on, and they're really shooting towards reducing the price of those rapid tests for self-testing, country policy and regulatory change, and then creating awareness and demand. So one of the big projects that's underway that WHO is a part of is the PSI UNAIDS STAR project, and that's catalyzing HIV self-testing in Southern Africa. So it's focused in phase 1 in Malawi, Zambia, and Zimbabwe, and in phase 2 we'll be adding South Africa. And so this implementation research has started this year, and we'll have some preliminary results coming up in July, which is great for the WHO guidelines. And really it's focused on identifying the distribution models, developing the right approaches, enabling the regulatory environment, encouraging that policy change, and really honing in on how self-testing is going to be the most effective and to really optimize it. And then phase 2 will really focus on shaping the market and bringing in these manufacturers to drop those prices down and scale up. So just some closing thoughts. The current approaches we're doing for HIV testing services are not enough. So self-testing isn't the only thing we need to do. It's a demand creation tool. It's never going to be a substitute for HIV testing services. It's something that's going to help us scale up and reach people who aren't getting into services at the moment. And it's an innovation and implementation, but the tests that we're using are tests that we're really familiar with. And there are technological advances and further opportunities for our optimization on the horizon. Self-testing has this great potential to increase the reach of testing services, the frequency of testing, and efficiency. So this is something that's really exciting about this approach. And as I said before, people are moving ahead without us. So there are a lot of pharmacies and locations that are offering HIV self-test kits today, and there's a public demand for it. So I think it really calls on public health professionals and stakeholders to find a way to make this a quality approach. And WHO guidance is on the way. We're getting very close, and if anyone's interested in peer reviewing and being a part of that process, please do let me know. And it's really urgent we work towards quality, WHO pre-qualified, low-cost, rapid diagnostic tests. And I just want to encourage everyone to think big and join WHO and working on this and optimizing self-testing so it's something that can really benefit the people who need it the most, the 46% of people who are living with HIV today and do not know their status. So just thank you so much for your time.
Excellent, Cheryl. Thanks so much for the presentation, the clarity, and just the overall great HIV self-testing. For people with questions, I see a lot are coming into the question box, so please keep submitting them. The box should be on your lower right-hand side. For the next presentation, we will hear from Dr. Archana Sarkar from the Mamta Health Institute for Mother and Child in India. So please take it away, Archana.
Hello everyone. A very warm greetings from India. Today we are going to speak on the pilot study on the feasibility of supervised self-testing using an oral rapid fluid-based testing method, which was conducted in a rural hospital among pregnant women in rural India. This study was done by Mamta and Mamta Health Institute and by Mahatma Gandhi Institute of Medical Sciences. This is a medical hospital in Wardha, one of the rural hospitals, and then International HIV/AIDS Alliance in UK. So, as we have seen that knowing a person's HIV status is essential to the success of HIV response, and reaching the first 90, the testing target, is the most problematic. And especially among pregnant women, in low and middle income countries, only around 44% of pregnant women are tested, and also nearly half of people are still unaware of their status. So in this situation, the new innovation technologies for testing are required, and feasibility studies on this technology are the need of the hour. So within that context, we'll go to the situation in India. The pregnant women, we have almost 29 million women giving birth to every year, which is a huge pregnancy burden for a country, and less than 40% of women get tested on for HIV. And nearly 14,000 HIV positive babies are born annually. The barriers being manifold: the stigma, the low awareness, the lack of trained workers, long distance, remote areas in India, rural areas. So these are the barriers. Within this situation, supervised HIV self-testing using a rapid diagnostic non-invasive test could be a potential solution. So we conducted this feasibility study with this following objectives. We wanted to do a supervised HIV self-testing using OraQuick as a screening test among pregnant women in a rural hospital. So the study was done in the hospital setting to assess the acceptability of this test among these pregnant women, the concordance with the supervisor and the pregnant woman while doing the test, and the feasibility of the self-testing supervised by the community health workers. So these are the objectives of this pilot study. And the method we followed was a cross-sectional study that was done between August 2014 to January 2015. And the study was done in Kasturba Rural Hospital. It's a tertiary level hospital which is catering to the rural population around Wardha. And within the study procedures, we trained the health workers, the community health workers, on the protocol and procedures for OraQuick test by using an instruction guide which was specifically made simple with pictorial demonstrations and easy language. So this was done first, the training was done. We also had seen the reliability that all the CHWs can do the test well, understand it, interpret it. So once we have done this, the study recruitment was done in the ANC, among the ANC attendees of the hospital in the outpatient department of the gynecology department of the hospital, So the inclusion criteria being the pregnant woman in the first trimester of pregnancy, and for this study we excluded women who had abnormal vital signs or who had fever or major problems or bleeding gums or who could not give consent. So within this study, once we have recruited and the women has agreed to participate in the study, pre and post counseling was given as per the standard recommendations. Briefly, this is the study flow diagram, how the participants were recruited. We excluded those who missed their appointments, who were under 18 and, as I said, other conditions. And ultimately, we had 202 pregnant women who participated in this study. We performed the self-testing by OraQuick and under the supervision of the community health worker. And these women, after they have completed this testing, they also did a confirmatory testing within the government-operated integrated counseling for testing center, the standardized HIV testing services in the country. So it was done just after the OraQuick test was done within the hospital premises. So we, as you see, 200 was tested negative and 2 were found to be positive, who were linked to the ART services. So briefly, this is the procedure of supervised self-testing that was followed. Once the woman has entered, the testing was done in a private room within the hospital. This is a public hospital, and self-testing kit was explained how to do it. It was explained by the CHW using a pictorial representation so that even a lowly literate woman can understand. Women performed the test under the supervision of CHW, and all the steps were recorded. And the test results were first observed and interpreted by the pregnant woman independently, and then by the community health worker independently. The community health worker recorded both the results, the result as interpreted by the pregnant woman and as by the CHW herself. And after that, as the woman was also tested in the ICTC center, which is within the hospital premises. The recommended counseling and linkages were done. All the ethical guidelines were followed. Ethical approval was obtained from Mamta Ethical Review Board as well as NGIMS Ethical Review Board. All the privacy and confidentiality were maintained. The data was collected in this tool, semi-structured questionnaire, to understand the experiences of the woman as well as the CHW while doing the self-test. An observation schedule was maintained so that the health worker can record each step of the observation while doing the self-testing procedure, and in-depth interviews were conducted with women. Both quantitative and qualitative analysis were done using SPSS for quantitative and content analysis, inductive content analysis for the qualitative. Now, this study was assessed in 4 major parameters. That's acceptability, where we assessed that how many women took the test among those who were offered. Then the concordance, that the agreement between the test interpretation as by the pregnant woman and as by the community health worker. So to see the inter-rater agreement between the community health worker and the pregnant woman. Then the sensitivity specificity was measured as the result interpreted by the community health worker and the result that came out in the ICTC. So these were these 2 tests were compared. These 2 results were compared for sensitivity and specificity. Whereas for feasibility we had both assessed the complete procedure of self-testing and in a quantitative way, as well as we had also some semi-structured questions on feasibility. So these are the 4 parameters on which it was assessed. The main finding was that we found that all women accepted the test, and the main reasons for liking the test were it was non-invasive, it was easy to do, and it had quick results. Unlike other studies, previously did not have a major, was not a major motivator in this study, was not found to be a major motivator. Only 2% did not like the study, saying that they were uncertain over the result. Otherwise, almost 83.7% said they preferred oral as compared to blood-based test, and 96% reported that they could recommend this to their other peer group, to their family members, to the other members, and even they also said that it should be available in public outlets so that one can buy it or one can get it if they need it. And these findings were also triangulated by the qualitative findings also. The concordance inter-rater agreement was very high and it was nearly 98%, although we found one invalid test by the supervisor and 2 invalid by the users which were actually found to be negative. The specificity and sensitivity was very high, for almost 100%, and except the one oral test which was invalid was excluded. Feasibility was again quite high. We assessed feasibility in 3 parameters like preparing the test, collecting the sample and doing the test, and reading the result. We found that taking the sample was the most difficult part of this. And then the qualitative findings also collaborated the same findings, where the clarity of instructions, time efficiency and invasiveness was found to be the most critical factors for this study. In conclusion, we have seen that this test was acceptable and feasible. This can be done in a resource constrained setting. It can be utilized by the CHWs with very low education, and this had concordance with the ICTC results. Further evidence is however needed. So in the way forward, as we know that trained lab providers and HIV self-testing has been recommended. Within that line, we are also exploring the use of rapid testing by the community health workers among pregnant women as a point of care screening. So thank you. I would like to end here and hand over to the moderator. Thank you.
Thank you so much, Archana. This was another excellent example, a concrete example of how self-testing among pregnant women in India is feasible and acceptable. And I think it links also nicely with the relatively new guidance from WHO on the lay providers as well, in terms of them providing support for self-testing. We're going to now hand over the questions, or start to go through the questions and start the discussion. Please continue to type your questions into the chat window. We will go through as many questions as we have time for, and any remaining questions we are going to answer via the community of practice that AIDSFree has set up. So we'll give you more information about that later. So the first question I'm going to answer is from Cheryl Johnson, and it's for the first presentation, Nomea and Anathi. When you talked about partner-related factors as an HTC enabler, what did that all include? So if you could answer that question, Nomea and or Anathi, that would be wonderful.
Hi. Yes, I think what it meant was that what the researchers found that most the participants said they would go and do a test if they were encouraged by the main partner. This speaks to the whole issue of multiple concurrent partners. But if the one who is deemed a main partner and who would encourage the participant to go and test, they would go and test. So that's why an enabler in terms of that.
Okay, thank you.
Hello?
Thank you, Nomea. So I think response to that question, we'll move on to the next question from Yawara. And Yawara asks, was geographical accessibility to HTC a barrier to testing? Geographical accessibility. And I would add just part of that, of my own question to that, and I noted that ART availability was not a factor in uptake of men, and that at this stage in the response is somewhat surprising to me. And I was just wondering if you guys could comment on that as well.
Okay. I would take it that this is directed towards Vincent. You know, I mean, when we look at the research findings, it's just like this is research that helps us get into the mind space of men, how they think in this era where you think some of these findings are. But geography is not a problem. What they might not, what participants found the problem was the facility-based testing, that going in there, the attitude, the structure, the design, but it's not male-friendly. Knowledge about ART and HIV was high. It was not necessarily an enabler. At the same time, people were not actually they were not encouraged by knowing about it. And I think that's why the implications are that we do need, there's so much progress that has been made in terms of ART from, either when people are taking of the tablets and treatment, and now we fix those combination. People are just taking one tablet per day, but it's knowledge among those who read and hear about this. It's not publicized as, condoms. Maybe we test and start in this country, as well as some of the studies that are being conducted in terms of PrEP. These are some of the things that will actually make men to say that, actually dispel the myth that, an HIV test that is positive is the death sentence.
Great, thank you, Nomea.
Yeah, thanks. The next question came in from question/comment. Maybe you all could respond to it from Marie Diodane. Cultural aspects still remain a big barrier in our society, and I just wondered maybe we could start with either Anansi or Chana, to talk about some of the cultural aspects that came out in your studies.
Should I answer?
Say again.
Hello?
Yes,
yeah. Yes, the challenge is because we did it in a hospital setting, we did not face any challenge in doing the test because it was done under supervision. And although there were few women who expressed questions like what is the test and what is the accuracy of the test, like how it is, how close it is. So these were the questions that we explained there. And other than that, there was not much challenge in implementing this because we had a supervisor who was supervising the test, and some women experienced difficulty in swabbing their gums, for which we provided the CHW provided assistance, and it was done privately. Only the CHW and the woman was there in the room. So these were some of the challenges that we faced. And apart from the permission that we took the permission from the hospital, from the medical department, and the gynecology was also a co-investigator within this study. And as for the next question, that how it can be rolled out in highly stigmatized and reluctant to test. One thing would be that because we are involving the community health workers there, whom this pregnant women have a lot of trust on them because they are involved with them in their delivery of regular maternal health care services. So involving a CHW for this self-testing would help them in counseling, and also they would accept this test as a test which they can take as a screening tool. And this can be really helpful in rural and remote areas where the ICTC could be very far off, and also in the Indian setting where there is so much of pregnancy burden. So this can be a useful strategy. So we have already seen that the acceptability of among these women, at least among these 202 women, was very high.
Great, thanks, Archana. Oh, sorry. Just two more questions on self-testing, and this can go to both Cheryl and Archana. Somebody, Jonas, raises the question of the issue of self-testing in settings where there's minimal privacy. So in rural settings where, for instance, people share rooms, do you think that would be an issue? And then I would add to that question, there was another question raised about the role of self-testing in PrEP. That's pre-exposure prophylaxis, which is rapidly being expanded as well. So if you could comment on both of those things, it would be great.
Sure. Can you hear me?
Clearly.
Okay. Okay, great. So for rural settings, I think self-testing could certainly play a role in rural settings. And a lot of times people talk about self-testing as home testing, but it doesn't necessarily have to mean in the home. So it can be where people feel safe with somebody that they trust. So I don't think we should be limited to thinking about just in someone's house. I do think it raises an important issue of privacy, disposing the test kits. Where do you put the test kit after you use it? Could you put it? I know there's teams in Tanzania that have asked, oh, could you dispose it in a latrine, or is it something just for the general waste system? How does that work? And I think those are really good questions. And to me, it's it's similar to the way we would dispose of condoms or other HIV prevention, and especially the oral fluid test kits that have very minimal risk for biohazardous material. And for the finger stick tests that are being used, they all have retractable lancets. So I think that's something to think about. For the PrEP, this is a really good question as well. So there's a lot of groups that are doing sub-studies on self-testing. One issue that we've identified is with the oral fluid tests, self-tests and professional use tests. For someone that's on ARVs or using PrEP, there can be lower sensitivity for the oral fluid. So there's one study coming out of Thailand that's showing that the self-test may lengthen the window period when people are using PrEP as compared to just the facility-based testing. And that's just with the oral fluid, just to clarify that. And people that are on long-term treatment, we know that they often come up as HIV negative, and the sensitivity of that oral fluid test can be fairly low. However, the finger stick tests, we don't really have any information of how they perform among PrEP users. We do know on people that are using ART that while there may be a decrease in sensitivity, it's very slight. I've only seen a few studies looking at this so far, and there hasn't been really compelling evidence telling us that would be problematic. So there are a lot of possibilities to use self-tests within PrEP to reduce facility visits, as kind of a mechanism for behavior. If people want to self-test every month or every 3 months in between their facility-based visits and testing, self-testing will never replace the facility-based testing that you need for PrEP or without PrEP, but it might be something that can serve as an in-between.
Just to respond to your question, in our study, the PrEP previously was not, it did not come out to be a major motivator, and it seemed because it involved a group of pregnant women, so probably for pregnant women, privacy did not come out, was a major issue. So we could do this very, very easily, and also we found that in the second study that where we are using as a community testing, using by the community health worker testing, there also we are finding that these PHWs are able to do it in the lowest facility level, known as a sub-center, or it's like a low facility level. So it can be done very easily in the rural level with in a low facility setup. So that is one thing that we have seen in our study.
Okay, great. Thanks to you both for that answer. We have time for just one more question, and then we'll wrap up. And I think the question from Dwayne is really relevant for this. He asked to maybe address stigma into reaching the first 90. He thinks that the webinar did not address this strongly as it should have. However, I think it was addressed kind of less. We didn't directly say stigma, but I think it was definitely addressed in the South Africa and the India study in terms of feasibility and acceptability. But until we deal with stigma, none of these strategies will get us to where we need to be. So maybe you could each take a few minutes and talk about how your work is addressing the issue related to stigma and testing. That would be wonderful. Thank you.
Hi, this is Anasi from Nagam from UNAIDS South Africa. I think we didn't have enough time to probably go to delve into each area the formative research did cover, but stigma was one issue. It definitely came up as a fear for people to actually get tested, as well as disclosing their status, a fear of people in their community knowing that they were getting tested and possibly getting HIV as a barrier to going to services, and a fear of nurses sharing their status in the community, because people are all part of the same community, and that definitely came out in the study. Unfortunately, we can't show you sort of how we took the demand creation, the formative research and applied it to the visual development of the PSAs, but the PSAs definitely tried to get into some of the fears that came up in the study and the stigma around knowing your status and even talking about the fact that you know your status proudly. Another piece that I didn't touch on deeply was that in addition to the PSA, that's a fictional character that many South Africans can relate to, we're going to do some complementary sort of documentary style ads that will run either on television or a taxi TV that runs in taxis that many South Africans use as mass transportation. And they're actual stories of people that are positive, that are thought they were positive but are negative, or as well as a discordant couple. And it's all about getting around this issue of knowing your status and the stigma of knowing your status and getting tested. So I agree with you 100% that stigma is a huge issue. It's at the heart of a lot of these themes that we picked up on, and that we do hope to address it at least in a small way through this demand creation activity.
Great. Thanks so much. So we've got 2 minutes left, and I'm going to take one of those 2 minutes just to ask a final question. This one's of Cheryl and the WHO. And just looking at your presentation, we've got guidelines on HIV self-testing that are in process. We have an evidence base that is growing in sub-Saharan Africa and around the world. And we have kind of some products that are emerging that are probably more cost-effective than those being deployed in Western countries. Can you just give us kind of a timeline? If I'm in the Ministry of Health, I mean, I'm a program and we really want to implement and try out HIV self-testing, where are we and what can we do, and what are the next steps?
Excellent. That's a great question. So I'm pleased to have some answers, maybe not fully, but we have been working with the Global Fund, and there will be an operational research note on self-testing coming out at the end of this month. And so that will enable countries to ask Global Fund for money to support implementation, pilot implementation, and operational research for self-testing. So that's something we're really excited about, because that's a great way for countries to get started, find the distribution systems that work for them. Do they want community-based? Do they want to do internet or pharmacy-based? Do they want to do some other facility-based models? We're seeing some really exciting approaches offering HIV self-testing to female women presenting at antenatal clinics to then give to their male partners to really increase male partner testing. And that's one of many different approaches that are being tried. So I think that that would be something to be thinking about. So first step, I would say, working on the policy change, look at the WHO current testing guidelines, what we outline as the technical considerations, and we also have a technical update that's a great place to go with where to start. Think about your Global Fund kind of applications and what you're doing there. That's a potential option to think about. And there's lots of pilot projects underway globally. So getting plugged in with those groups, looking at the evidence map is a great place to just get started. So I'd start with pilot projects, start the policy and regulatory change now, be talking to Ministry of Health, get on the phone, talk to them about self-testing, let them know WHO is developing guidelines if they haven't heard already, and get involved in the guideline process. I think it's something where, as a global community, we need people as peer reviewers, we need programs a part of it, giving us case studies, giving us examples, and the challenges that you're dealing with to make sure we're addressing them in our guidelines.
Okay, thanks, Cheryl, and thanks, everyone. I'd like to thank all the participants for giving their time and expertise today. All three presentations were very relevant to getting to the first 90, increasing our numbers. In the next few days, you will all receive an email with a link to today's recording. Before we close the room, I want to encourage you to take a minute to fill out the poll questions that you can see on front of you. And I also would like to encourage you to join the AIDSFree HIV testing services community of practice if you haven't. We are going to try and take the remainder of the questions and answer them as a team using the presenter's knowledge and post the answers slowly and surely on the community of practice. So that's another way that you can continue to participate in this discussion more actively. And the link will be on the email, and I believe it will be accessible as well via the screen. It's in the center of the screen. So thank you so much to all of our presenters, and thank you to Vincent Wong for co-moderating and the ideas behind this webinar. And we'd just like to say thank you all for participating. Thank you.
Thanks, everybody.
Thank you. Thank you. Bye-bye. Thank you. Bye.